What if fasting was making your hormones worse, not better? If you're a woman over 35 and you've hit a wall with fasting, this episode is for you. Today we're diving into the science of fasting failure, why burnout, blood sugar crashes, and belly fat aren't just about willpower, but about timing, insulin, and your hormonal blueprint. We welcome back to the podcast Cynthia Thurlow. She's a nurse practitioner with 20 years in clinical medicine. Her TEDx talk on intermittent fasting has over 15 million views, and she's helped thousands of women reclaim their health span and their hormonal harmony by listening to the data their bodies have been whispering all along. We're going to cover an approach to fasting that works for women across all age ranges, and how Cynthia has had to unlearn everything she knew about fasting when she hit perimenopause. Welcome to Treated with Dr. Sara Szal. Cynthia Thurlow, welcome back to Treated.
Thanks. So good to be here.
I want to dive into metabolic health, especially for women over 40. Fasting, the role of fasting, how it works for some of us until it doesn't. Why is that? Hormones. And also, I love looking under the hood with you and talking about what personally is working for you, what maybe worked in the past, no longer works. So that's what I want to cover today. How's that sound?
Sounds great.
So let's start first with fasting. I mean, you exploded on the scene with your TEDx talk on intermittent fasting. You've got a book on intermittent fasting. I've got a sister right now who's doing one meal a day. How do you approach it? And also, how has your conception of fasting in women changed over time?
I think I'm going to respond to your second question first.
Oh, good. Okay.
Because very transparently, I've been very open about this, that over the past year, in the wake of my father's death, because one of the things that contributed to my dad's death was sarcopenia and frailty.
Yeah.
How critically important maintaining muscle mass is as we are navigating middle age and beyond. In order to put muscle on, I am doing less fasting and more digestive rest, which really represents 12 to 13 hours of not eating a day. With that being said, I think fasting is a very important strategy. When we look at the statistics that anywhere from 92 to 93% of Americans are not metabolically healthy, it begs to question, is meal frequency working well for most Americans? I would actually argue that it is not. And for that reason, I think most individuals do better with eating less often, whether that is a formal fasting or non-fasting situation. I think most people do better for metabolic health purposes by eating less frequently. And that could be 2 to 3 meals a day in a feeding window. I think for a lot of individuals, it's understanding that men and menopausal women in many instances seem to have greater latitude with fasting than younger women do, certainly women under the age of 35.
Okay.
And so I think that when we talk about fasting, we have to talk about what life stage a woman is in and then gauge, is it the right strategy for them at this time in their cycle or a stage of life? You know, if someone's pregnant, breastfeeding, I would never recommend fasting. It's, there's too many other things that need to be prioritized. But I think in many instances, we've taken what is, I think, a very good, one of many strategies that we can use with middle-aged women, and we've gone to extremes. And that's what I get concerned about, both as a clinician and then both from working with thousands and thousands of women, seeing what happens when women don't manage their lifestyle choices with their life stage or even their hormones.
So tell us what you're doing right now. So you mentioned digestive rest. You mentioned prioritizing muscle mass. So what are you doing right now versus what you did maybe 10 years ago?
Yeah. So 10 years ago, I was doing a 16-8 pretty consistently. I mean, rigidly, 16 hours, fasted with an 8-hour feeding window, 2 meals. That was probably as most as I was eating. Now it's generally 3 meals a day, 3 boluses of protein, a lot more weight training. And for me personally, I'm probably more liberal with my carbohydrate intake. I think that for a long time, I was very much in that tribe of low carb. I was not ketogenic. Sometimes people throw that out there. I'm like, I've never been ketogenic, but I was probably a little too strict about my carbohydrate intake. I feel like for me, with the amount of weight training that I'm doing, it puts me at a disadvantage if I'm not replacing some of the glycogen stores that I have, utilized while exercising and lifting heavy.
How many carbs are we talking about?
100, 150.
Oh,
Before I was under 50, 60 all the time. So I'm having larger portions. I know for me personally, I can tell you I do really well with vegetables and I do fine with fruit. And so I will occasionally have some grains, but I limit that. I just don't feel as good if I had a cup of rice, I wouldn't feel great, but I can do half a cup easily.
Women need carbs. I feel like this is a critical part, whether you're looking at hormones, when you're looking at sleep and production of serotonin, or you're looking at thyroid function. There's a way that women who try a ketogenic diet or they restrict their carbs, it can backfire.
Yeah.
It can affect your sleep and it affects your thyroid. So it sounds like you discovered this on your own. And I love that you're liberalizing carbs. The other thing, I haven't fact checked this, but tell me what you think of this. When I was experimenting with different carb amounts in myself and also in my patients, I found that if you want to drive protein inside of cells, you need carbs to help with that. Do you agree with that?
I would agree with that. And I've been humbly surprised. For me, I think when I look at bioimpedance readings, so body composition readings, I can say I'm the N of 1 when I'm just looking at myself. And, it took me 9 months to put on 3 pounds of muscle, but I was able to do that. And my goal is a couple more pounds of muscle. But with that being said, the things that I have changed is no fasting or less fasting, more protein, more meals, more carbohydrates. And I've been able to facilitate that. And so I think for the N of 1 experiment, that absolutely has been the case. I think what I find really interesting is when I'm working with newer patients and they start telling me about how much exercise they're doing, what they're eating, I'm like, let's just track your macros for a week. And really, I'm doing that because I want to know, are they actually eating enough food? A lot of women that are getting into middle age, the methodology used to be, I eat less, I exercise more, I lose the weight.
Right.
That all changes.
Calorie counting.
Right. All that SECO, all that calories in, calories out, all changes for us. Maybe the gym bros can get away with that. My teenage boys can get away with that. That is not how it works in our world at this stage of life. And so helping them understand that in many instances, they are underfueling their body. They're over fasting, over exercising, underfueling their body, which is this kind of athlete triad that a lot of research is done around. And
what's the cost of that?
Could be substantial. I mean, you could hasten, your transition into menopause. You can deal with, immune system dysregulation, leaky gut. I see a lot of women who have tremendous amount of hair loss.
It drops your estrogen.
Yeah.
I mean, that's what I see. It's part of the female athletic triad.
And so
it leads to bone loss. It also, I was just looking at some data on how estrogen is so important for emotional health and for vagal tone, for keeping your heart rate variability in a healthy range. And when estrogen starts to decline, you're less likely to do that.
Yeah.
And if you're contributing to it by undernourishing yourself, you could be making matters worse.
Yeah. What I find interesting, and this is research that I did for my new book that'll be out next year, really looking at bone health. Yes. I'm really excited about this book because it's kind of been this passion project, but it was really looking at the conflux of how many young women, I was one of them, underlying PCOS that was not diagnosed. So I have irregular periods. I start oral contraceptives as a 16-year-old, not for contraception, primarily to regulate my periods. How many women are put on oral contraceptives before they've gotten to peak bone mass? Where they're put on Depo-Provera, which we know has a larger net impact on bone mass, especially in younger women, like teenagers. And then over the course of the time, you're on the pill for 15 years. That's and right. You never hit peak bone mass. So how many women go into their 30s or later that are already osteopenic, not because they were restrictive with their food intake, not because they were purposely doing anything that was putting them at greater risk. They just never got the opportunity to build that healthy bone. And so I find that that conversation I find really, really interesting because there's this complex interplay with bone health and the gut.
Yes.
And so if you're dealing with people who, grew up in a lot of trauma, so they've already got some contributors that their gut microbiome composition is probably not as healthy as someone that grew up in a different environment.
They
it's
have
like
dysbiosis, so an imbalance with their microbes. They probably have leaky gut just because of the cortisol and the stress.
So it's like it just fuels this unwinding of bone health. So I find that I'm so glad that you mentioned that about this low estrogen state, but it really does. It's this domino effect. And I think about those people that are maybe a little more susceptible heading into middle age. Maybe they've never had a DEXA. They used to do them. They would do them for fun at the hospital I worked at. So I got them done in my 30s. So I was able to see what my bone looked like before having kids and after.
Oh,
and
tell
you
us
probably
about
know.
that.
Well, I had healthy bone before kids, and then I had 2 kids fairly close in age. I breastfed each for a year, and I didn't realize how much bone deposition is impacted by breastfeeding.
Huge.
And I was like, why aren't we talking to our patients about this?
Why aren't we doing DEXAs?
Waiting until 65, you're pretty much putting women at even greater risk. I mean, that to me is criminal, truly. Everyone should have a DEXA done as a baseline assessment in their 30s, certainly before they go into menopause. And if they're osteopenic, realizing that there are things we can do, even more reason indication to put women on, whether we want to call it menopausal hormone replacement therapy or hormone replacement therapy, even more reason to get them on estrogen.
Yeah. I don't like calling it menopausal hormone therapy because I think you should start way before that.
It's like a mouthful. I had someone tell me, honestly, I had someone in my DMs tell me that I was not using the correct term. And I said, I know women that are in their late 30s, early 40s that are already on hormone replacement therapy. So I don't think they want to be told they're on menopausal
I started in my late 30s.
Oh, you're way ahead of the curve. I was I waited. No one talked to me about it until I was in menopause. Like, I just didn't know any better. So I always say, don't do what I do. Like, start it way ahead of time. My quality of life probably would have been better in my 40s had I started earlier.
Yeah. It's a good question to pose because we've talked about the burnout that you experienced at 42 to 43.
Oh, I needed it then. I clearly needed progesterone, and I probably needed estrogen because being only 115, 120 pounds, even with weight training and all the other things, I think that I probably was always in a lower estrogen state. I mean, I think that was just where my body, that probably contributed to my body habitus and a slew of other things. I don't think I ever had until I went into perimenopause, really these, wildly fluctuating estrogen levels, which is probably why I didn't feel stellar, just by virtue of the fact I probably had never, other than in pregnancy, probably had never experienced levels that were so varied. And obviously this is your area of expertise, but I think that probably exacerbated or magnified some of the experiences that I had in my 40s, for sure.
I would assume so.
Yeah.
So there's so many things I want to pick up. Let me see if I can remember them since my estrogen is not what it used to be. So number one, you've talked about thin phenotype PCOS. How did you get diagnosed? And how long did it take? Because the delay in diagnosis is ridiculous with PCOS.
So it's interesting. It wasn't until, so I got married at 32. We started trying to get pregnant almost immediately because I was like, I should not put this off. So 33, I had a wonderful GYN, Freda Jones in Northern Virginia. I love her to pieces. And I was tracking my temperature. And I was like, I don't think I'm ovulating. And she looked at my charts. I'd only done it for 3 months. And she said, I 100% agree with you. I want to refer you immediately to reproductive endocrinology because at 33, I don't want you waiting another year because that could be a huge differentiator. So,
okay, Frida was a baddie. I like that she was
awesome.
Not going based on the guidelines.
No, she was just a wonderful, wonderful clinician. I hope she's still practicing because she's amazing. Saw reproductive endocrinology. They did a workup for both my husband and I. At the time, my husband was doing a lot of triathlons. So he had like suboptimal sperm count. They thought because he was on the bike so much.
Sitting on the bike.
Yep. Sitting on the bike a lot. And then, he said to me, I think that you need Clomid. And so I said, okay, we're going to do Clomid. And of course, like that was not a time. I think I was just very trusting. I was like, I'm going to do Clomid. And he said, we'll do intrauterine insemination, we'll do IUI, but I'm going to let you know, it'll probably be 4 or 5 cycles before you get pregnant, if at all. And, I want you to think that, there's IVF over here if you want to go that direction. And I have I have an amazing family member who's a GYN, my cousin. And she said, I want you to think about creating boundaries around what you are willing to do to get pregnant. She was like, I want you and Todd to be thinking about this now, because I see people who are devastated when plan A, plan B, plan C doesn't work.
Yes.
And the most amazing thing is I went on Clomid, I did my first IUI, and I got pregnant. And so that was the trajectory of how I found out I had confirmed PCOS. And then I was able to get pregnant very easily.
Was your testosterone high?
No, it was never high. Like
so anovulatory cycles,
low progesterone. Like when she was testing me, I think it was days 19 through 22. She was like, "You're really low. Like it's no wonder why you're not getting enough of a surge of progesterone." And so it was interesting because I never fit that physical phenotype. I didn't have excess hair growth. I never had acne. And so it was like, I was put in this, like, we're presumptively assuming you're thin phenotype PCOS. And I was never insulin resistant. Like we've always tracked my insulins are like 2, 3, 4, 5 at the most.
Did you get your postprandial insulin checked then?
Yes, I did when I was pregnant.
Okay.
And even then it was good. And it's interesting. I have a SNP that, and it's interesting. I spoke to a couple endocrinologists about this. I have a SNP that if I consume too much, like if I were to have pancakes or a bowl of ice cream, my body excretes a lot of excess glucose in my urine, which is the mechanism of action of some of the diabetic meds, and names of which I'm blanking on right now. But they were saying, like, if you have normal blood sugar, blood glucose, your insulin's low, your A1C is perfectly within range, your C-peptide's normal, and then you just have this aberrant, like I had eaten pancakes and got a urinary tract infection and went to, I'm sorry, it's probably more information you want to know.
No, I love this.
Went to an urgent care and I was like, I'm an NP. I think I have a UTI. They did a urinalysis and they're like, no, you have diabetes. And I was like, no, I don't.
Because you're a hyper excreter.
Yep. And I said, no, I swear. And they're like, we can't prescribe, you have diabetes. You need to go to the hospital. And I was like, I don't have diabetes. I just ate a pancake breakfast with orange juice, which was not the right decision. But what came out of that was the realization, because that then did this huge endocrinology workup to demonstrate. And my friend who's an endocrinologist was like, you do not have diabetes. There's nothing. She's like, I see diabetes every day. You do not have diabetes. You actually have this SNP. And then I had to like write it down because I couldn't remember what it was. But she said, you're just one of those people that when you consume too much sugary foods, which I don't do, but this was a long time ago, she said, that's how your body gets rid of it.
And you were able to find that out. A lot of people don't realize that they're hyper secretors.
I'm like a hyper absorber. I'm a hyper secretor. I mean, I am like special all the way around.
It's happening for you,
yes,
not to you.
But if you can imagine, like I'm in an urgent care and my husband's like, my wife does not have diabetes. She's like, you have diabetes. I was like, I do not have diabetes. It was like, we're having this argument back and forth. I was like, I understand your parameters, but I promise you, I do not have diabetes. I had to beg for an antibiotic. I was like, I'll go to my primary, but I was like, I'm having pain. Yeah, it was an interesting situation.
Yeah. So the other piece I wanted to pick up from what you said, I want to hear about what you're doing for weight training right now. Like what kind of strength training, how much time, what are you really into right now? Because back in those burnout days, when you were 42, 43, you were doing kind of a CrossFit type of exercise. So what do you do now since you're obsessed like I am with muscle mass?
Yeah, I would say I work out twice a week, just solely strength training. And I work out with a trainer who holds me accountable. That was my decision. But she only works with middle-aged women and she's incredibly knowledgeable and she's a kinesiologist. So she understands body mechanics. I would say that we do compound exercises. We are constantly changing now because I get bored really easily.
That's part of the seeker phenotype.
I get bored really easily. So she's constantly challenging me. But, I love doing things like I like farmer carries, and I like things that feel very functional, that make me feel strong. And I remind myself that part of why I'm doing the things that I'm doing is so that I am able to live independently for the rest of my life. And so that is very much worked into, we're on and off the floor. That's something that she kind of works into. She said a lot of people just have women on machines or they're just on a rack.
Yes.
And so I'm constantly on and off the floor, also with mobility work.
Yes.
I also have a really fantastic massage therapist who's like a sports medicine guy. And he'll, especially because your fascia gets tight or you're sitting a certain way. And so I think that those two things together, lifting heavier weights, less reps, making sure that you're constantly challenging yourself, not so that you get hurt, but also identifying like where there's a weakness. And then she tortures me with unilateral movements. So she kind of,
because she loves you.
Yes. And she tells me that. She's like, Cynthia, you've got a book launch coming up and you've been telling me I have to think about this. Like I'm physically training for the book launch.
Nice.
Like that is my mindset, is I'm getting myself ready to be able to show up and have plenty of energy and use my mental faculties and not lose my train of thought, because there's nothing worse. It's like, did I put my estrogen patch on this morning? Yes.
I have to put it on the calendar. So 2 times a week, how long? 45 minutes?
It's an hour.
An hour.
You work out for an hour and then I stretch. And then on other days, I am a huge believer in posterior chain work. So I like doing solid core, which I jokingly say is still the hardest thing I do, just because I just think it's hard. It's difficult, but it's difficult in a good way. And it stretches my muscles in my body in a completely different way. And I make sure that I have enough clearance around my weight training so that I'm not compromised, because there's nothing worse than being sore and trying to do that class. And then I do a lot of active movement throughout the day, no less than 10 to 12,000 steps a day, I think is part of that.
That's great.
Yeah. So just being active, I think, is important.
Back to fasting. So you were talking about how with fasting, we have to contextualize. We have to know, especially for women, where they are in their life cycle. Now, embedded in that, it seems like men respond to fasting much more readily than women do. So this context becomes more important in women. So you were talking about the reproductive years, postpartum, perimenopause, menopause. Give us the 911 give us the 411 on how the approach to fasting should change with where women are in their life cycle.
I mean, I think it's really important because I think the message for a long time has been, I'll say for women under the age of 35, everyone should be fasting. I would argue that's completely terrible advice for younger women. I think if you are a woman who's not metabolically healthy, you have PCOS, you suspect that you do, I think a couple days a week of fasting is actually probably good for you to do to help with, maintaining glucose excursion and just improvement of blood sugar regulation. I think if someone is lean and fit, I think 12 to 13 hours of digestive rest is great. And I wouldn't want to do more than that. I just see far too many women that are just not eating at all. And whether a woman is choosing to conceive at that time in her life, her body's perception of fasting is that they're in many instances where they're just starving themselves. So I think that being very conscientious about when you are eating, when you are fasting, where you are in your cycle is going to be critically important. For those, our bodies are designed to conceive and carry children, whether we choose to or not. After 35, and I think of anyone over 35 to 50, you're probably in that perimenopause range, and it becomes even more important. Are you metabolically healthy? How physically active are you? Or how lean are you? I never should have been fasting as much as I was, 6 years ago. I just didn't know any better. Now I do. I feel like I've had enough experience where I'm like, wait a minute. What's the greater good over time? If the goal is to maintain lean muscle and you're already lean, why would you put yourself at risk for losing muscle mass? And that's where these bioimpedance scales are so helpful to really get a sense. Where are you? What's the snapshot? Versus if you are the bulk of the population where you're not metabolically healthy, maybe you've got a little bit of fatty liver. Maybe you do have PCOS, like typical PCOS phenotype. Maybe you're an individual that is being told you have borderline diabetes. A little bit of fasting can be a powerful hormetic stressor. Again, where are you in your cycle? If you're from the time of bleed week up until ovulation, you have a lot of flexibility. Maybe a few days a week of fasting can be very helpful. If you're very physically active, be careful, make sure that you have a sense of how much food you're actually consuming. Because it gets back to that athlete's triad where you just have women who are unknowingly not eating enough food chronically, habitually over time. And what maybe people don't per se understand is that your body is ingenious. If you don't consume enough protein, it'll just break down your muscle.
That's right.
That catabolism of your muscle. And that is much harder at that stage of life to build muscle. I know from personal experience because I lost 15 pounds in 2019 during a hospitalization. And it has probably taken 6 years to put that muscle back on, really and truly, which probably wasn't helped by how much fasting I was doing. That's a whole separate tangential conversation. But I think women in perimenopause and menopause, like the bigger issue, I think, is that we become less stress resilient.
Yes.
So we have to be thinking about context. If you are not sleeping, your personal life is a hot mess, you're not eating well, if you are adding more fuel to the fire, if this is an additional stressor, it may make it harder for you to achieve whatever goal it is that you're looking for. On the other hand, if you are sleeping well, you're giving your body nutrient-dense whole foods, you are otherwise happy, you're fulfilled, you're managing your stress in some capacity. I would say it's not 5 minutes of meditation once a week, but you're managing your stress. Then a little bit of fasting around that, follicular phase may not be a non-beneficial thing to add in. So I always think it's in the context of the greater picture. What's your overall stress pattern like? How are you feeling physically? If you are exhausted, please don't add in fasting. If you're not sleeping through the night, please don't add in fasting.
This is really good. So I want to maybe pose this as a question for our listeners and viewers. So if you are fasting and you're noticing that you're more irritable or your sleep is disrupted, you got to take a look at this. Like, listen to the words of Cynthia Thurlow right now and maybe drop a fire in the comments so that we can see you and help you. And I want to get into some of the details of why this is happening. So I feel like cortisol is an important part of this story. And I also want to just go back to when I was a teenager. I wonder if you had any experiences like this. I was not diagnosed as having anorexia, but I was pretty close to anorexic. I remember trying to fit into my 501 jeans. I remember trying to wear mini skirts and I'm kind of a plump phenotype and it just didn't work. And so I started restricting food. And I remember dropping about 15 pounds rapidly, most of which was muscle because we weren't measuring body composition then. And even when I was a teenager at age 16, it was hard to get that muscle mass back. And it kind of set up this scarcity theme in my genetics, the gene environment interface that was not good. I want to bring in the hormones. So cortisol, estrogen, progesterone, testosterone, how those layer into the way that you approach fasting. And, I think of cortisol as this wear and tear hormone. It is part of what triggers catabolism, like the breakdown of muscle. So tell us about the hormones now those fit into the picture.
Yeah, I mean, you're really talking about a hormone hierarchy. And in our bodies, regardless of what we want the hierarchy to be, if our body perceives that we are chronically stressed, so if we're dealing with high cortisol, it is going to subjugate everything else that comes underneath it. So those sex hormones are going to be shunted as not a priority because our body will prioritize survival over reproduction. It's as simple as that. But when I think about cortisol, it's one of these hormones that gets a bad rap. It's a very important survival hormone, but it also does things in our bodies to ensure we survive. So it'll break down muscle. It will, ultimately impact immune function. If we are dealing with chronic stress over time, you may find you're more susceptible to infections, opportunistic infections. It can lead to a weakening of the very small, one layer thick lining of the small intestine, which can lead to leaky gut, which can lead to underlying food sensitivities. People will start talking about they're bloated, they're not digesting well.
They're inflamed.
They're inflamed. And at the basis of everything is inflammation, you're correct, and oxidative stress. And so when I speak to women about hormetic stressors, and fasting is one of many that we can use as tools, it's helping them understand there's a right time to fast and there's a wrong time to fast. So when I think about someone saying to me, I'm exhausted all the time, I can't sleep, my hair is falling out, I don't have enough energy to exercise, let alone think about sex, I'm not making good food choices because I'm not sleeping well, so I crave McDonald's. when I really would like to be eating chicken and broccoli, it's helping them understand that a lot of what's going on, it's an inopportune to add in the stressor of fasting. It doesn't mean that something as simple as 12 hours of digestive rest might not be a good option for them, but it's helping people understand with this hormone hierarchy, which explains a lot. The other piece is that if cortisol's up, glucose is up, insulin is up. So if someone's trying to lose weight, it can explain why they are struggling to lose weight. It can explain why they have changes in body habitus. We have 40 times more cortisol receptors in our abdomen than we do in other parts of our body. So that cortisol belly that you sometimes have patients describe can be a direct reflection of just not taking care of yourself.
Cortisol belly.
Yeah.
Cortisol face.
Yes.
Cortisol has all these effects.
Yes. You have this little buffalo hump, which is even more attractive to think about. But helping people understand cortisol is not a bad hormone, but in the context of chronic unrelenting stress, we become less stress resilient as we are navigating perimenopause and menopause. Progesterone is a very important hormone, but it's the first one that's typically dysregulates at this time in our lives. Less progesterone means that we have less GABA upregulation. This is a neurotransmitter, helps with reducing anxiety, has this calming effect. When we take progesterone, we get a byproduct called allopregnanolone, which has a very sedating effect. For people that take progesterone like myself, I'm like, I love my progesterone at night.
I love that allopregnanolone.
Yes, it feels great. But I think for many, many people, it's helping them kind of put these pieces together. And that might look different for everyone. But I think that in our toxic diet culture, in our culture that really emulates and adulates thinness and skinniness over being strong, which is what I really try to emphasize, is that we want to be strong and live independently for the rest of our lives. And that's kind of what I really, really emphasize. We have to be thinking long-term. We have to be thinking, are choices I'm making today ultimately going to end up in losing muscle mass, which will lose to frailty. Frailty leads to falls. Fails lead to a lack of independence or being able to live independently. And you and I have seen countless examples. There's nothing more sad than a 50-year-old that can't get off on a bedside toilet in the hospital, because that's not a good sign. So fasting is not a bad strategy. It has to be used discreetly and eloquently with the right patients at the right time. And that's what I think is that important distinction. It's not right for everyone all the time. And to your point, yes, men have a much easier time navigating fasting than women do, for sure.
Yeah.
It's kind of unfair, right?
It is unfair. I want to bring in another topic, which is sensitivity. Mm-hmm. And I'm curious, I haven't seen any data on this, but I'm curious if those of us who are more highly sensitive maybe have a more difficult time with fasting.
I think like any type of hormetic stress, cold immersion. I think you had a conversation with me, whether you remember it or not, but you were talking about, a lot of people are doing cold plunges. And I think I said to you, I could do like 30 seconds or a minute in the shower or do cryotherapy and I'm fine. But the thought of a cold plunge would send my cortisol like through the roof.
Totally.
And so to your point about this, being a more sensitive person, it makes a great deal of sense that hormetic stress doesn't need to be as extreme.
Yeah.
Maybe it's 14 hours of not eating. Maybe it's 13 hours of not eating. And I think it's knowing yourself well enough to know, who you are. I think, again, the gift of middle age is that I spent a little bit more time being introspective than maybe I had the time to do 20 years ago when I had a newborn who's almost 20 now. It just gives me the opportunity to reflect a little bit differently about some of the choices. But I think that we're in an age where the biohacking community has a tremendous influence. And this is where I see women that are doing like crazy amounts of sauna. Sauna has benefits. Let me be clear. Cold exposure has benefits, but it's all that fine line of like, who are you as an individual? And that's where bioindividuality, I think, is so critically important, and knowing yourself well enough to say, I just need a little bit of stressor. I don't need to go, sit in a cold plunge for 20 minutes and, get out and have hypothermia. Like that would not be ideal.
Let's drill down on sensitivity, because I feel like this is something that's been relegated to the psychological literature. And I feel like it has such an important role in the way that we think about men and women and what's optimal, especially in terms of protocols and biomarkers. So I texted you the quiz this morning. You ran your quiz. What did you learn?
I guess I'm like medium range sensitive person, but there were definitely questions. Like as an example,
Yeah.
when I am listening to a symphony or I'm at a play or I'm watching a ballet, I get very emotional. Like I take it all in and it's such an immersive experience for me. It makes me very emotional.
Yeah.
And I was like, oh, that's so me. That makes so much sense. It also explains, and maybe it's a byproduct of how I grew up, but I know the litmus test of a room when I walk in.
Yes.
And it's like, I know instantly because I was that, that empath. I was always trying to calm things down, de-escalate things. And so for me, I know that litmus test in the room. Yes. I mean, I can tell. And for me, I've learned the other piece of that is I need more divine feminine energy in my life and less masculine energy. And so when I walk into a room, that is something that I can feel that shift pretty significantly. I'm not sure if you feel similarly.
Oh, for sure.
Yeah.
For sure. Especially immature masculine.
Yes.
Those days are over. So what I'll do is I'll link to the quiz by Elaine Aronson in the show notes so that people can figure out if they're HSP. I'm 24 out of 26 positive, so I'm very highly sensitive. And I feel like, yes, it's about reading a room. It's about, these nonverbal cues that you pick up on. It's about being lost in the experience of art or, some new context. And it's also about people who are HSP can pick up on changes in the culture sooner than people who don't have this sensitivity. It's like a canary in the coal mine analogy. And we get overstimulated more easily.
Yep.
So I think about some of these hormetic stresses like fasting or cold plunging and how it can make us feel overstimulated and get beyond our window of tolerance and maybe contribute to the burnout that we're trying to prevent as a result.
Yeah.
It's also, it's only 20% of the population is highly sensitive, and yet we're the ones who make up most of the therapy clients. And
because we're attuned to it. And I'm curious, where neurodivergence intersects with that, because the older I get, the more I think I am on that neurodivergent spectrum.
Oh, I definitely am. No question.
Again, my wonderful cousin, we have these deep, in-depth conversations. She's like, we're both neurodivergent. You realize that? And I was like, no. And then I was like, yes, you're right. It makes so much sense because, the one thing for me that I think typifies that for me personally is that when I get interested in something, it's almost like I get lost in the learning process.
Yeah. Like a flow state.
Yes, I went on a peptide interest binge.
Oh, and me both.
And I am now so fascinated with peptides.
Are you taking some right now?
I am.
Can we talk a little peptides? What
Absolutely.
are you taking?
I am taking thymosin alpha.
Yeah.
I am taking BPC 157. And this is the experiment of the N of 1 that my provider was willing to try, using a GLP-1 at microdosing to see if it'll drop my Lp(a).
Oh, interesting.
So that's been our experiment of N of 1 because I don't need to lose weight. It was, and I feel like I have to qualify that. I think there's different ways that we can use them, and I think GLP-1s are fascinating. Like the more I learn about them and their ability to impact bodies in a very positive way, the more fascinated I am. So I went down I'm now down that peptide rabbit hole, but I bought all the books and took a course and interviewing experts. And I mean, my whole team was like, oh my God, do you need to create a course for people? Because now you know so much. And I said, but it's when I get interested, it's like I have tunnel vision.
Yeah.
In a good way. It's a good habit to have. It's not a malignant habit, but.
Well, peptides are super interesting. When I think about that hormone therapy plus and how it's not just, I have perimenopause, I have menopause, I need hormone therapy. It's, the entire building the base of the lifestyle support so that you can meet those hormones in the middle. And then what are some of the climbing the mountain moments, like taking peptides or even considering biologics? So I'm with you on the peptide conversation. I've been doing N of 1 experiments for about 8 years.
Oh, how
so
cool.
I'm completely obsessed. You also brought up GLP-1, so I feel like we should talk about that for a moment.
Yeah.
How are you approaching it in your practice? How do you think about GLP-1s? Are we setting up a vast uncontrolled medical experiment right now?
Well, it's interesting because there's obviously there's two different ways that I think about them. There's obviously a very metabolically unhealthy population that would have tremendous benefit for a variety of reasons from utilizing them in a very straightforward way, whether it's Wegovy, Zepbound, et cetera. Then what I find even more interesting on the other side is I think we're just at it's like the tip of the iceberg. We're just starting to understand and appreciate at much lower levels.
Yes.
What can we modulate from an inflammatory pathway? What can we modulate in the body from utilizing them? And so that's where my nerdy brain just kind of gets curious about what are the other ways that we can use these drugs? Now, the thing that I get concerned about very transparently is that there are medications that people can get in a pharmacy. There are medications that can be compounded. And then there's this gray space in between. And because I'm a nerd, I was watching, it was like a New York Times report, and it was talking about people that were getting access to all types of peptides in the dark web or in outer space. And they were talking about, well, we're not sure where this is. I have to, I get this vial and I have to reconstitute it. And I think it's from China.
Yes.
But you don't know what you're injecting yourself with.
Yes.
And so I think there's this other conversation about responsible access. And that's something that we don't want it to be a them or us. We want it to be at some point, I hope that everyone will have the ability, if it's appropriate for them to utilize GLP-1. So getting back to your original question, I think I'm very excited about all the people that are finding tremendous success with food noise reduction.
Yes.
I've had people say to me, I don't think about food like I did before. I can actually sit down and
they get their lives back.
Right. It's all of a sudden, it's almost as if part of their brain has just stopped firing.
Yeah. Food becomes neutral.
And I think that's very important because we have a culture, again, toxic diet culture that's been shaming people for years and years and years for a lack of control. And yet we didn't really fully understand, those GIP receptors that we have in the brain that are, quieted down with these drugs. And how many people are less likely to go on and develop the sequelae of poor metabolic health? Maybe they'll avoid having a heart attack. Maybe they'll avoid developing full-blown diabetes or fatty liver or specific types of cancers that we know are directly attributable to poor metabolic health. I think on the other side, for the people who are metabolically healthy that are curious, so GLP curious, if that begs, those individuals, the question is, I have a couple questions or thoughts. Number one, for a thin focused culture, are we going to develop people who are just not going to eat?
Yeah.
That's because I've had friends tell me, I just don't even think about food anymore. I was like, but do you eat? It's okay if maybe the food noise is quieted down, but if you're not eating, then we deal with the sequelae that everyone talks about, this loss of muscle mass, which can be catastrophic.
The sarcopenia.
Yeah, which is, not a question of if, but when. And that just accelerates after 40. And so the other thing is when you're talking about a healthy population, I look at peptides as the icing on a cake. It is not per se the thing that I'm thinking out right out of the gate because lifestyle is lifestyle and that has to be the foundational element. And then thinking about, when appropriate, bringing in hormones or other types of medications. If someone has wacky lipids, I take Zetia to be totally transparent because I'm a hyperabsorber and that dropped my ApoB to 60. So I think for transparency purposes, I think it's important to share that. But I think for a lot of individuals, it's we're on this little slippery slope. And I'm hoping that it doesn't then become a who can afford the peptides and who can't. Finding access to high quality products, I think is really important. And that's why I am the first person to say, if I'm in a group and someone's talking about how they're, they have no medical training and they're hawking peptides. I'm like, wait a minute, peptides are powerful. They should really only be prescribed by, my opinion, licensed healthcare providers.
Yes.
Because then you also know you're getting access to real product and they're not going to be inexpensive. All the compounded stuff I take is not inexpensive, but at least I know I'm getting what I'm paying for.
That's right.
And so I think that there might be opportunities for individuals. I think Kyle Gillette, who's a physician, mentioned on social media recently, there's like 1 or 2 US-based companies that are making like 2 to 3 high-quality oral peptides that people can take. And he was saying, these are usually where I refer people to. But I think in most instances, I just think about the people out there who aren't thinking about the greater good,
That's
making
right.
sure that they're not getting people in trouble. That's my concern, is just a safety perspective.
Safety, for sure. And this theme that we have throughout this podcast of be strong, and, preparing for the transition of perimenopause, menopause, keeping your bones strong, keeping your muscles, maintaining your muscle mass, maybe growing your muscle mass as you've been doing 3 pounds in 6 months. I like that. So any final words as we wrap this up? I love this GLP curious. I wrote that down. So in terms of being strong, what do you advise our listeners?
I think first you have to sleep. So if you're not sleeping well, you got to dial that in first. Then if you are someone that's interested in weight training, and I hope you are in some capacity, and that could start with body weight exercise and progress to smaller weights and then eventually get to heavier weights so that you're got the right body mechanics. Doing strength training 2 to 3 days a week. And then I think it's also like the nutrition piece is critically important. We have to eat enough protein. I jokingly say I feel like protein has become a second job. On the days that I can't get enough protein in, I will buffer it with some essential aminos just for full transparency.
Good.
Like yesterday was a travel day. There's just no way I'm going to get enough protein in. So on those days I buffer with essential aminos. And then, adding
And how much do you aim for protein?
100, 110, ideally.
Yeah.
And even on like a microdosing of GLP-1, I can do that. So it also tells me it's the right dose for me. It's not enough to blunt my appetite, which is what a lot of friends have said. That was like their biggest thing. I just don't feel like eating. I feel kind of nauseous. I don't want to eat. I think the other piece is having social connections, I think is also very important. So whether it's you're lifting with a loved one or you're doing meal prep with a loved one, just having that social connection piece. We know how important oxytocin is, which is not just released when a woman has an orgasm. It can be released just by like hugging your loved ones or hugging your pets or just doing something joyful.
You have 2 doodles.
I have 3.
You have 3 doodles
I
now?
do. Yeah, it makes this sound crazy. We have 2 senior doodles and we have a Bernie doodle puppy. Oh. And he is adorable and he's 70 pounds of just mischievousness. He's adorable. But I think, having something in your life that brings you joy. So oxytocin lowers cortisol. And a lot of the conversation today has been around understanding that we become less stress resilient. So that's an easy way to, get your cortisol down in a healthy way. But those are like the high level things that I think about. Oh, and I would lastly add like things like creatine can be very helpful for muscle mass support.
How much do you take?
10 grams a day.
Yeah, me too.
10 grams.
I started at 5. I'm up to 10.
It's good for brain health. And the other thing that I think is really interesting, I just got introduced to a supplement called Fortitropin. And so that is supposed to help with lean mass development. It's like an egg white, fermented egg white.
Yes, I've heard about this.
My dog's even on it.
Oh.
My one Labradoodle who's 13, who's a little sarcopenic. And the vet even was like, I'm all for it. So Fortitropin is something that I've been taking the last 2 months, and I'm starting to see some improvement. I haven't done another bioimpedance reading, but we'll do that probably next month. And then I'll know exactly. Then I can quantify, like just because I feel like something, I'm like, okay, I need to actually like how much muscle mass to fat-free mass do I have? And then I can objectively give numbers.
Show me the data.
Yeah, exactly.
Maybe you'll text me.
I will. Be happy to.
So Cynthia, amazing as always to be with you. I feel like we're going to do a farmer's carry as we wrap up this podcast so that we can build our muscles together. Thank you for going deep on fasting and cortisol and oxytocin and GLP curiosity. I love being with you and so appreciate the deep service you give to the world.
Likewise.